Hi everyone, welcome to ResearchMD.com. Another great presentation today. Let me introduce myself. My name is Pramil, Cheriyath. I'm a physician, program director, internal medicine residency, transitional residency. I teach medical students and residents on a regular basis. I'm also associate professor of medicine at two large medical schools in the United States. And so today we're going to teach you everything about hypothyroidism. Make sure you watch our presentation we made yesterday. That's about the thyroid hormone, about the physiology, how does it produce and how does it work, okay? So today our topic is what? Hypothyroidism. Okay, just jump into. When you look at the hypothyroidism, it's good to know this. Let's go back and visit the pituitary axis. You got hypothalamus. What happened? You got thyrotropin releasing hormone. That's kind of come up here and go to the anterior pituitary, and then you stimulate the TSH, and the TSH comes here, and then TSH kind of go on the thyroid and then start acting on this cascade of reaction. Okay, the first thing that happens is like you got this sodium potassium pump working over here, creating a gradient in the basolateral membrane. I mean, this is the whole thyroid cell. You got the colloid over here, you got the apical and the basolateral membrane. Okay, let's go back and visit our basolateral membrane. You got the ATP sodium pump, which is creating a low gradient in the thyroid cell about the low sodium. So what does the low sodium does? That also activate the sodium iodine symporter, and then that bring sodium into the cell with iodine. So we're just kind of looking at the iodine, and the iodine come here through this iodine channel, go through the apical membrane, and go through a series of reactions, which is oxidation, and the other one is like organification, and there is coupling reaction, okay? And then you have the T4 and T4-3 formation. Then you go to the peripheral tissue, and you got this enzyme, deiodinase 1 and 3, kind of T4 is converted back to T3 and reverse T3 also. Okay, some of them may be converted to T2 also. So that is what like how the hormone works. Now, so again, we're talking about definition about hypothyroidism, right? What is hypothyroidism? Underactive thyroid gland resulting in deficiency of thyroid hormones. We talk about the epidemiology, more in females. In the United States, the prevalence is around 4.6%. Now let's talk about the etiology, okay? There's like primary hypothyroidism. What happened in the primary hypothyroidism? Number one thing you have to know about like autoimmune thyroiditis. What happened in the autoimmune thyroiditis? You got the failure of the T-cell mediated inflammatory response. There's cytokine release and infiltration of thyroid by the lymphocyte, and all of this causes like autoimmune thyroiditis. And then you talk about the next thing is the iodine metabolism. It can affect two ways. There is decreased iodine. When you have decreased iodine, what happens? Decreased hormone formation. When you have increased iodine, there is pituitary, this is a hypofunction of the thyroid gland, okay? And then you got irradiation, thyroidectomy, genetic disease, infiltrated disease like sarcoidosis. And then there is infection. When you talk about the infection, remember, it can, like even the COVID-19 has been shown to cause primary hypothyroidism. Medication, when you talk about the medication, the most important thing, the lithium, how does it affect? It affects this iodination, like iodine transport over here, okay? The other thing, it also affects in the coupling process. Those are the two areas the lithium can affect it. And then when we talk about the some of the industrial and environmental agents can also cause like primary hypothyroidism. Now let's look at the central hypothyroidism, which is already happening in the hypothalamus and the pituitary. That's where the central process, right? Anything kind of going over here. One, hypothalamic lesions, and then you got pituitary lesions, infection, inflammation, even sarcoidosis in those areas, and congenital causes could be there. And now when you look at the peripheral hypothyroidism, it could be like consumptive, like increased consumption. In that case, what happened? You have like sometimes you have tumor cell. They increase the expression of we talk about the deiodinase enzyme like 1 and 3. It's actually convert the T4 to T3. In this case, tumor causes increased expression of type 3 or type 3 deiodinase. So there's increased consumption of the thyroid hormones. And the other thing is like resistant to thyroid hormones. Now let's look at like what happened to the patient. What did the patient usually complain about hypothyroidism? What is the most common? I think they say like fatigue, okay? Thyroid hormone can affect any part of the body. Another big hormone, just like growth hormone. So let's look it over here, like what happens, right? You got appearance, puffy face, loss of eyelid, not eyelid, loss of eyebrow, okay? And then you got sensory, decreased hearing is also common. Thyroid, they can form the goiter formation. Metabolic, it can cause like weight gain. And then gastrointestinal, there's constipation, musculoskeletal cramps, fatigue, and tiredness. And also remember about the temperature. They usually feel what? They feel cold, right? Those things is important also. Now, neurological, they can say cognitive dysfunction. Depression also is very common. You got slow speech. Cardiac is also, we have to be very careful. Decreased ejection fraction cause bradycardia, pericardial effusion is there. Hypertension, pulmonary causes can cause like pleural effusion, and then reproductive causes also very, very important. It can cause like amenorrhea, irregular period, infertility, and all, decreased libido. And extremities, there is paresthesia and brittle nails, so it can affect any part of the body, okay? But most common patient usually complaint is about the fatigue, and then you do investigation, then you find out all, but again, it can affect any organ in the body. Now, let's look at the investigation. How do you investigate? What's the first thing you have to do is check the TSH level. Okay, don't jump into doing all those tests first. Always go back to doing the number one test is like TSH. Okay, when you look at the TSH, if it is increased, then we go to our next step. What is that? If it is increased, then you have to check the free T4 level. Okay, so if the free T4 is normal, then what is that called? The subclinical hypothyroidism. Okay, that means TSH is increased, but free T4 is normal. There is subclinical hypothyroidism. What do you do in that group of people? The problem with subclinical hypothyroidism, that can convert it into overt hypothyroidism kind of later on. So you also want to check this anti-thyroid peroxidase antibody in that group. If that is high, there's a good chance they'll be converted into overt hypothyroidism later, okay? So let's say you got increased TSH and you check the free T4 next, and the free T4 level come back low, then the patient got like overt the primary hypothyroidism, okay? That's our diagnosis, primary hypothyroidism. Increase TSH, and then you do the next step, you check the free T4, and then free T4 is low, that's primary hypothyroidism. Let's say you check the TSH, okay, and the TSH is decreased, and you check the free T4, is also low. And then you have to think about the central hypothyroidism causes we already talked about. This is a pathology kind of happening in the pituitary and the hypothalamus region, okay? So I think I'm just going to go and kind of summarize this one more time. First, you don't go into the point of ordering all the steps. You just need, first you check with the TSH, if it is increased, and then you go with the free T4, and the free T4 is low, then primary hypothyroidism, and then you have to worry about subclinical hypothyroidism where free T4 is going to be normal. In this case, you check the TSH, and the TSH, let's say the TSH is decreased, and then you got free T4 is low, then you got central hypothyroidism. Obviously, like we have to think about the treatment. How do you treat it? Now, age less than 65, you give 1.6 microgram, okay? When you diagnose with the primary hypothyroidism, you start with 1.6 microgram per kg. If the older, like greater than 65 years, you give only like 1.0 microgram per kg, because the more you give, they can affect the heart functions and all that. So you have to be careful. So look at the age, greater than 65, you start with the low dose, less than 65, you give 1.6 microgram, okay? Now, when you talk about the subclinical, if it is in the pregnancy, you start with you have to give like 1 micrograms per kg, okay? And then if they're subclinical and you check your TSH and TSH come back greater than 10, okay? The next step, you look at the age. If the age is less than 70, you start with like low dose 1 microgram per kg. Let's say if it is age greater than 70, you don't need to treat it. You just kind of watch it unless they have like cardiac disease or something like that. And you monitor every 3 to 6 months, okay? Now, subclinical, you diagnose with subclinical and the TSH level is like less than 10, then you can only monitor them like 3 to 6 months. You don't have to treat and all that, Okay, if you have subclinical and if they have like the patient is like cardiovascular disease, it's probably a good idea to give like a low dose, low dose T4. Okay. Now, how do you take this medication? How do you recommend this patient? They should take before like 30 to 60 minutes before breakfast is the ideal time to take the thyroid supplement. Now, the next thing we need to know, like, when do you monitor? Let's say you start the patient, you diagnose with the primary hypothyroidism. What do? You check the TSH only after 6 weeks. Okay? So the patient came in, after 6 weeks, you go back and check the TSH, and then you make the changes, you wait another 6 weeks to make, check TSH. Don't order like every 1 week or 2 weeks or anything like that. 6 weeks, okay? Now, let's say like after 6 weeks, patient came back to normal and TSH is normal, everything is looking good, then you have to go back, like you can check it every 6 months or every 12 months, between 6 to 12 months, okay? Now, when we talk about some of the medication can interfere with the thyroid hormone. So when you take the supplement, you have to be very careful. Let's say you take calcium carbonate, proton pump inhibitor, iron, sucralfate, any of this you take, they can decrease the T4, like thyroid hormone absorption, whatever you're taking. And then you got the estrogen that can also cause like thyroid hormone decrease level. And amiodarone, always remember, is one of the important drug kind of affect the thyroids, right? It can inhibit the T4, T3 conversion from the peripheral tissue, like acting on the deiodinase. From T4 to T3 conversion, it could affect and have like an impact on the when you take the medications and all those kind of things, okay? Remember that. So just in a nutshell, let's go back and look at our board one more time to make sure we know when you talk about this, most common in females, okay? Then you got all these causes, you got the primary and you got the central, and you look at the peripheral causes, and then you look at all this can affect any part of the body. Make sure you know about the cardiac conditions and the fatigue and the temperature intolerance in these people is also very, very important. And then always order the TSH first, and then you check free T4, and don't forget about subclinical hypothyroidism. And then you have to differentiate, it's like, this is primary hypothyroidism, or is it central, means it's coming from the hypothalamus or the pituitary part. Okay, once we know how to treat it. Depends upon the age. If it is less than 65, we give higher dose. If it is if it is greater than 65, we start with the low dose. Be careful about pregnancy. Even subclinical hypothyroidism in pregnancy need to be treated. Let's say if the patient have hypothyroidism and get pregnant, you may need higher doses, but to make sure that they become euthyroid, okay? And then subclinical hypothyroidism, be careful. Is it less than 70? You start with the low dose, and then if you have cardiovascular disease, you should treat it. If it is greater than 70, not recommended treatment at this point. And then let's say like subclinical, and based on the TSH level, it's important, less than 10 or greater than 10. If it is less than 10 TSH, you just kind of watch it, like every 3 to 6 months you can recheck it, and then you take the medicine 30 to 60 minutes before breakfast, and monitor only like every 6 weeks. Okay, so everything's stable, you check it like maybe like 6 to 12 weeks. 6 to 12 months. That is good. That's a good thing. And always kind of remember about some of the drugs can interfere. Again, thank you so much for watching. We'll be back with another presentation. Please help us to subscribe to our channel so we can make more presentations like this. Okay, have a blessed day.